Welcome, everybody. Thanks so much for joining us. We're just going to wait 1 or 2 minutes while everyone gets into the webinar. Thank you so much for joining us today. We'll just give folks 1 more minute to join, and then we'll get started. All right. Well, happy Monday, everybody. My name is Assemblymember Marc Berman, and I represent the 24th Assembly District. Thank you to everyone for joining our webinar today, and a big thank you to our esteemed panelists and moderator. Healthcare is a critical issue, and even more so during the COVID-19 pandemic. As you all know, rising healthcare costs impact residents of the 24th Assembly District. Addressing affordability is also important to healthcare providers in 8024, including Stanford Medical School and Hospital and El Camino Hospital. And I did realize that I forgot to mention, my name is Assemblymember Marc Berman, and I represent the 24th Assembly District. Rising healthcare costs are also a statewide concern. Less than 2 weeks ago, the Assembly Health Committee held an informational hearing on healthcare affordability. This hearing provided background on healthcare costs, the drivers of healthcare spending, data needed to advance cost containment efforts, healthcare industry consolidation, and how affordability concerns are hindering care for many Californians. Finding solutions to mounting healthcare costs is long overdue and more urgent than ever, as California will likely surpass 1 million cases of COVID-19 and 18,000 deaths this week. Today, we will discuss a policy proposal that Governor Newsom proposed earlier this year in his 2020-2021 budget, and Assemblymember Jim Wood, chair of the Assembly Health Committee, introduced in Assembly Bill 2817. Due to the COVID-19 pandemic, the governor did not pursue his budget proposal, and Assembly Bill 2817 did not move forward, but Assemblymember Wood has expressed his intent to reintroduce this legislation next year. I'm excited to provide a preview of this important proposal to my constituents today. I also look forward to hearing from the panel about the unique process that culminated in their recommended proposal to tackle rising health costs. What many often consider to be opposing stakeholders came together to identify solutions for all Californians. The story behind this proposal can be seen as a roadmap for policy development and coming together to address really complex issues. Speaking of coming together, I would like to take a moment to express my gratitude to Vicki Veenker, who was instrumental in convening these stakeholders and is a powerful advocate for collaboration to identify policy solutions. Vicki and I were political opponents in 2016, but now we are allies and friends. This event would not have happened without her. Vicki Veenker joined Convergence in 2017. As managing director of the West Coast, she directs the California Health Reform Initiative, Convergence's first project outside of Washington, D.C. Vicki has a deep background in dispute resolution, having been appointed to the International Trade Commission and the federal court to their mediation panels. She has been named to the Silicon Valley Arbitration and Mediation Center's list of the world's leading technology neutrals each year since its inception. In 2002, Vicki was named one of California's top 20 lawyers under 40 by California Law Business. She was a partner at international law firm Shearman and Sterling and previously at Fish and Nave until she founded Veenker Law Offices in 2013. Vicki has been an adjunct professor of law at UC Hastings and Santa Clara University. In 2005, Vicki helped found and served as the first general counsel for women's professional soccer. She is on the board of WIRE, which works to increase the number of women in public office, and the board of the Law Foundation of Silicon Valley, which provides legal representation to underserved communities. So now that we have sufficiently enticed you all, Vicki, tell us a little bit more about this proposal.
Well, thank you, Assemblymember Berman, for that very kind introduction. I too am grateful that you and I have come together in true Convergence style. And we truly appreciate the opportunity to speak publicly with you, your constituents, with all Californians, and others outside this state who might be inspired by this proposal and the process that led to it. So thank you so much. So let's give each other a chance. It's time to put away the harsh rhetoric, lower the temperature, see each other again, listen to each other again. And to make progress, we have to stop treating our opponents as enemies. Those are the words of President-elect Joe Biden on Saturday night. And that is essentially what Convergence has been doing. Our founder, Rob Fursh, who I believe is on this call today from Washington, and who spent years as a staffer on Capitol Hill, including working for California's own Leon Panetta, Rob had a vision of a better way to make policy by getting to know those with whom you disagree, building relationship and trust, and really seeing them and listening to them. As Joe Biden also said, if we can decide not to cooperate, then we can decide to cooperate. Convergence creates a space and a place where policy leaders can do just that. So Convergence is a nonpartisan nonprofit that remains neutral on the issues and does not take sides. Well, we've chatted a link to our website where you can find out more. So instead of talking about the process in the abstract, I will describe how Convergence's California Health Reform Initiative came together. So before the Convergence California project, all of Convergence's projects had been national. So when we started out here in 2017, we had to introduce ourselves in Sacramento. We were the new kids in town. So we started to speak with policy advocates and policy makers to figure out, one, was the time ripe to convene a health reform roundtable? And two, was it already handled? Were there others who were doing this? So we spoke to consumer and patient advocates, health providers, insurers, business representatives, labor, academics, and more. We also spoke to sitting legislators like Assemblymember Calra in San Jose, who chaired the Long-Term Care Committee at that time, and Assemblymember David Chu, who was on the Health Committee in the Assembly. We also met with Senator Hannah-Beth Jackson, who turned out to be Rob Fursh's law school classmate, which was really strange because they didn't go to law school in California or DC. That was in Boston. So it's been a fun and interesting journey. So we learned that there was a sense of ripeness and even an urgency to make progress on dealing with the problems that Californians were facing in dealing with our healthcare system. We also learned that while California leaders had made really good progress and various groups had been meeting to address these problems, no one followed a convergence style process where disagreeing parties are gathered, a neutral facilitator manages the discussions, and what is said in the room is confidential to encourage candor. So we began to invite people to the table, following the convergence practice of making sure all perspectives and interests were represented. So to do that, as we built our table, we would ask, who are we missing? For example, when we went to see Senator Holly Mitchell and asked her who else should be at the table, she introduced us to the California Black Health Network, whose executive director joined us. Now you can find a list of others in our report, which is here, and we are chatting a link now to that report. So to give you a feel for the breadth of representation, a few of the others who joined us, and I'm just going to give you some examples, are Bill Barcelona, who represented doctors, Anthony Wright, who is a top healthcare consumer advocate, Lauren Kay from the Chamber of Commerce, Gary Cohen from Insurer Blue Shield of California, Micah Weinberg at California Forward, Kiran Savage-Sangwan from the California Pan-Ethnic Health Network, and many more, but you get the idea. So we first convened in Sacramento in October of 2018, about 2 years ago, and we met over the course of more than a year. We got into a rhythm of meeting on Thursday afternoons after the legislature adjourned for the week, having dinner and finishing our meetings on Friday morning. So I'll let the panelists tell you more about the content of the meetings, but generally we closed the doors, did exercises to let them get to know each other and build trust. We asked them questions about why they worked in the health sector, and we drew out their underlying values. Discovery of shared values led to discovery of shared goals. Recognition of shared goals led to deep and sometimes challenging discussions of how to achieve those goals. And it led to discussions of which goals were the most urgent and achievable. So specifically, our stakeholders explored promoting quality, increasing access, and improving equity, and ultimately zeroed in on a way to meaningfully improve affordability for consumers and workers by containing healthcare costs. So I'm not going to do the big reveal on their solution until I have the panelists on the screen with me, but they published the report in March with their recommendation the same week that, as Assemblymember Berman mentioned, the governor proposed an Office of Healthcare Affordability in his budget, and Health Committee Chair Jim Wood proposed a very similar solution in his bill last year. Then COVID struck. The bill was deferred, and our proposal was essentially quarantined until now. So with that, let me bring on the members of our, well, 3 of the members of our larger statewide group. And we're bringing you 3 members that hail from the Bay Area. So I want to start with Bill Kramer. So welcome, Bill. Bill Kramer is Executive Director for, hey, there he is. Hi, Bill. He's Executive Director for Health Policy at the Pacific Business Group on Health. Bill is also the Project Director for the Consumer Purchaser Alliance, an initiative to improve quality and affordability of healthcare. He serves on the National Quality Forum's Board of Directors and the Patient Center Primary Care Collaborative's board. Before joining PBGH, Bill led his own consulting practice focusing on health reform, finance, and business strategy for both public and private sector clients. And before that, for 20 years, more than 20 years, Bill was a senior executive with Kaiser Permanente, most recently as Chief Financial Officer for their Northwest region. He served as general manager for their operations in Connecticut, and early in his career, he managed marketing, human resources, and medical economics. So Bill has a tremendous and varied experience background. He has an MBA from Stanford Graduate School of Business and a bachelor's degree from Harvard. So welcome, Bill. Also joining us today is panelist Lani Chen. Welcome, Lani. Dr. Lani Chen is the David and Diane Steffi Research Fellow at the Hoover Institution and Director of Domestic Policy Studies and lecturer in the Public Policy Program at Stanford. Previously, he was a visiting fellow in health policy studies at the Heritage Foundation. Now, Lani, as you may know, is a veteran of several high-profile political campaigns, having advised 4 presidential efforts, including as policy director of the Romney-Ryan campaign, and served as Governor Mitt Romney's chief policy advisor. You may have seen Lani providing political commentary on CNN or other major news outlets, or read his writings in the Wall Street Journal, the New York Times, and other papers. In the private sector, Lani is chair of the board of directors at El Camino Health right here in 8024, and is an operating partner at New Road Capital Partners, where he helps to direct healthcare investments. Lani has not 1, not 2, but I think 4 degrees from Harvard, PhD and a master's in political science. a degree from the Harvard Law School and an undergraduate degree in government. So welcome, Lani, and thank you for joining us today. And third, we're going to go across the bay from the Hoover Institution at Stanford to the Labor Center at UC Berkeley, and I welcome Laurel Lucia, who is director of the healthcare program at the Labor Center at Cal. I told you we gathered divergent perspectives. Laurel has worked at the Labor Center since 2009, analyzing healthcare policy. Her recent papers have examined health coverage and economic impacts of possible Affordable Care Act repeal on California, California's Medicaid expansion, health insurance for immigrants, and the remaining uninsured in California. Her work has been covered in the LA Times, The Atlantic, and NPR. Previously, Laurel worked on issues affecting healthcare workers as a researcher and policy analyst for the Service Employees International Union, which may be better known to you as SEIU. And she has been an elected officer for 2 unions. Laurel received her master's of public policy from UC Berkeley and her bachelor's from Stanford. So thanks to all of you for joining us today. And more important, for all of the time, effort, and goodwill that you put into our work in Sacramento over the last couple of years. We are truly grateful for that. So let's start with why each of you participated in the process. So Lani, the Democrats control both houses of our state legislature, and you are a conservative. So why was it important for you to spend time as part of this consensus building effort?
Well, Vicki, I've participated in a number of dialogues convened by the Convergence Center for Policy Resolution on national healthcare issues, on national questions of how we can create a more upwardly mobile society. And here in California, where I live and work, healthcare is a huge concern, obviously, for residents of our state. We see it in our community here in the Bay Area. So for me, the opportunity to sit down with people who don't have views like mine, who are looking, though, to try and find common ground on some big problems. And certainly healthcare affordability is one of the biggest, if not the biggest problem that we face. That's a very appealing thing to me. Look, I think building consensus, coming together, being able to figure out where we can agree is very important. And in this time and age when things are so remarkably polarized, when really there's enough reason to doubt the sincerity of those who don't share our political beliefs, it's nice to be able to come together and to have very frank conversations. And look, you know you're not going to agree going into it with everything that everybody has to say, but that's okay. The only way you can figure out where there's agreement and where you can come together is if you sit down and actually hash it out. And I think that's what the process that Convergence has designed. That's what our project was able to get toward. And I think it's a very effective and meaningful process, even if it doesn't yield a ton of agreement. The fact that it can yield some, I think, is newsworthy in and of itself.
Terrific and agreed. So Bill, some of our participants came into the group knowing each other well, either as frequent allies or as frequent adversaries who could give each other's stump speeches. You three don't live in Sacramento and each had to travel in from the Bay Area for our meetings. So how well did you know everyone at the start? And how did relationships develop over time? And what do you think will be the effect of that going forward?
Thanks very much, Vicki. This was a great opportunity to work with people not only across the political spectrum, but also from various stakeholder interests. We know that the only way to make progress in healthcare, or costs and quality and equity, is if we have employers and consumer groups and labor groups and hospitals and physicians, health plans, all working together to pull in the same direction. And so the convergence process provided a great opportunity for that. I've also, like Lani, had the opportunity to work on convergence projects at the national level. In fact, that's work I did with Lani and others. But the work in Sacramento, I did know a number of the actors in advance, but not all. I don't spend all my time in Sacramento or all my time on California state policy. And while I knew some of the people who participated, it was an opportunity to meet or to get to know much better those who were involved. I think the process we went through, learning where each of us is coming from, not just at a surface level, what our policy positions were, but what our basic values are, what we're trying to achieve in the long run, was really critical. And that allowed us to have the frank and open discussions and arrive at consensus on what I think is a very good and bold proposal that came out of our work together.
Fabulous. And I want to compliment all of you on the civility of the conversations. There was never a harsh word or an epithet or name calling. I mean, passionate disagreement, yes. Disappointment sometimes in people taking certain positions, yes. But personal regard, yes. At least that's what I saw. So Laurel, is that what you saw, and did that surprise you?
Yeah, I think if you had told me 2 years ago that this group of participants would find agreement on really any policy recommendation related to healthcare costs, and that we would do so without things getting ugly, I would have been surprised. And I think the conversation was always very collegial, and people were really trying to understand each other's perspectives, and we're really listening deeply. And I think it's a testament to what can be accomplished if the right factors are in place. I think it was really important that the group that was brought together was not only representing a wide range of views, but that each of the participants were really committed to finding common ground and to listening to each other. And I think the amount of time we spent together and that the process started as somewhat open-ended really allowed us to kind of meander a little bit and find the policy idea that there was the most energy around. And the facilitation process was really helpful in building the relationships and understanding of each other that we needed to come together on this idea.
Yeah, and I remember that early on, there was a little frustration with some of the meandering. People wanted to get to it, but it kind of took that to get to something that we could really center on. So let's look a little more closely at the problem. I said at the top that your group zeroed in on improving affordability for all of us by controlling costs. So the California legislature is currently between sessions. But last week, Assembly Health Committee Chair Jim Wood held an informational hearing on affordability. And we were thrilled to learn then, as Assemblymember Berman mentioned, that Assemblymember Wood announced he will reintroduce his bill to enact your solution next session. So how bad is this affordability problem? In our report, for those of you who've seen it on the, have gone to the link that was chatted, but we can put up our slide. We had figure 1 on page 9 is a chart that was prepared by the California Healthcare Foundation, and it gives you an idea. You can see that over the last 15 years, inflation, the green line at the bottom, has grown by 44%, but the cost of premiums, the blue line, steeper, has grown by almost 250%, or more than 5 times the rate of inflation, and thus is taking a bigger and bigger chunk out of families' budgets. So Laurel, you testified at that hearing last week and had a fabulous slide deck, and a couple of the slides that you showed really struck me, so I'd like to share them. So on the slide that's showing now, the blue bars relate to healthcare affordability and the yellow bars relate to housing affordability. Well, we all know we have a housing affordability crisis. So what's going on? What's shown here in this slide?
Right, this is from a survey that California Healthcare Foundation sponsored in 2019. And as you can see, more than 2/3 of California adults reported that they were very or somewhat worried about unexpected medical bills or affording their out-of-pocket costs when they use healthcare services. And that's a higher percentage than the 54% who are concerned about affording their rent or mortgage. And we all know how big housing affordability is in terms of problems in this state. So I think this just puts into perspective how dire the healthcare affordability problem in this state has become. And in addition to people reporting being worried about unexpected medical bills and out-of-pocket costs, half said they were worried about prescription drug costs. And of those who had health insurance, 44% said they were concerned about insurance premiums.
Yeah, which is amazing to see that juxtaposed. But you had another striking slide on the impact of these affordability concerns. Tell us about this slide.
So what this worry about healthcare affordability translates to is that people aren't getting the care they need at the time they need it. People are skipping their prescriptions, cutting pills in half, skipping recommended tests or treatments, not getting the care they need, whether that's medical care, mental health care, dental care. Over half of California adults reported at least one of these problems. And what's not shown here is affordability concerns not only present barriers to accessing care, but they can also mean financial hardship. People have to cut back on other basic necessities due to high healthcare costs. They take on debt, and in some cases even have to declare bankruptcy.
Mhm. Okay, and there's one more slide if we can go to from your deck that I'd like you to explain to us.
So healthcare premiums for a family plan have exceeded $20,000 a year now. I think the Kaiser Family Foundation describes it well. That's like you and your employer buying a new car together every single year. And as an hourly equivalent, that's $10 an hour. So healthcare benefits make up a huge part of workers' total compensation. And research has shown a connection between rising healthcare costs and wage stagnation. And this is a less visible impact, I think, to a lot of people about rising healthcare costs. People see their own share of the premium going up each year. They see their deductible going up. But the effect that rising healthcare has on wages is also a really major consequence.
Right. Wow. So I think we've established we have a problem. So what's the solution? Well, these very smart and experienced people, along with their colleagues from our group, recommend that each year the state set a cost target that health insurance plans, doctors, hospitals, and other providers have to meet, with efforts to help them achieve the target and consequences for not meeting it. So this annual cost target tells insurers and providers that they should not increase what they charge by more than that target, which is a percentage each year. So that's the gist of it. I didn't do it justice, but that's the gist of it. So let's start with Bill. Bill, why do you think this is a good idea, and why do you think it will work? And please feel free to restate it if you can do it better than I.
First, let me just reiterate the data you just showed and what the implications are, how serious the costs are. Of course, there's a direct impact on affordability for patients who are forced to postpone or avoid needed health care, or it squeezes out money they have for housing or food and so on. That's just a terrible situation. But there are secondary and effects as well. Employers pay the large majority of costs for people who have employer-sponsored insurance. The burden of health benefits costs crowds out business investment, slows down job growth. It crowds out workers' wages. It's been one of the main reasons why wages have been held down over the last 20 years. And in terms of public sector health programs, it crowds out investment in things like education, public safety, and transportation. So this is a very widespread problem and is crowding out other things, whether it's people's food and housing, business investment and wages, and public sector investment. But in terms of our proposal, the solution, first step is we have to have better data, more consistent data, so we can get a full picture of the problem. The information we have is largely done now through one time only projects, a big research project, where they have to find the data, create the data, massage the data. It's funded by a foundation or someone like that. And then it goes on the shelf. and then it gets updated maybe in a couple of years. We need to have an ongoing process to regularly collect the data on not only on healthcare utilization, but the prices that are charged and the total cost of care, along with, by the way, quality. That needs to be part of this equation as well. And until we have that, we're only taking kind of scatter shots at a target that keeps bobbing and weaving. We need to have a clear picture so we, the public, as policymakers, can see what needs to be done. Second key element is targets. There needs to be meaningful and realistic targets for what costs should be. And frankly, I believe there needs to be a reduction in the total costs of care, not just a slowing of the cost trend increases. Those targets, though, should recognize that there are some hospitals, some health systems, some clinicians that are actually doing a really good job. So there's enormous variation in the cost. Some are very expensive, some are much less expensive. And those ones that are less expensive are often delivering the best quality care. So we need, in setting the targets, it should not be across the board. It should be putting a strong cost containment target on those that are in the upper end of costs. A third key element is technical assistance, providing help to health systems, hospitals, clinicians to get to where they need to be in terms of costs. In other words, rather than saying, you're on your own, here's a target, good luck. The state should be helping pool together resources to provide the technical assistance to those groups so they can help achieve those targets. The final key element is consequences. This has to be more than an academic exercise. This has to be more than just gather data, set targets, provide technical assistance, and hope for the best. We won't get the results we want unless there are real consequences for those groups that continue to have high costs that are putting a burden on consumers, on employers, and the general economy.
Well, thank you, Bill. And I just want to address quickly a question that came in asking why this bill didn't get passed in the spring that would enact this. And it's COVID is the one word answer. It was a budget item. It, along with many other things, got deferred when we had to rejigger on the fly, and Assemblymember Berman and others had some extraordinary sessions in Sacramento to redo things. So it was, some said it was paused, some said it was deferred, but it was really that it was a budget item that had to be deferred. So Lani, at last week's informational hearing that the Assembly Health Committee heard, members of both parties talked about the problem. Assemblymember McCarty described a local school district that was running out of money because of healthcare costs. Assemblymember Chad Mays said, quote, "We keep asking these questions. I was on the city council in 2002 and we were worried about the rising costs of healthcare. It's 20 years later and we never get to a solution. I'm a market guy, but this is a market failure." So do you agree with him? Is this a market failure? And if so, why?
Yeah, I mean, we certainly do have market failure. I think one of the things about the plan that's interesting, if you notice, it combines both these cost targets with efforts at increasing price and quality transparency, which has been an elusive thing, I think, over these many years. A lot of people, whether they are conservatives or progressives, have talked about the need for greater transparency around pricing and quality, and ensuring that those who purchase healthcare, meaning employers and payers, as well as the final end consumers, have a better sense for what's going on. And if you look at healthcare systems in various states that have been more successful, what you generally find is that those states have tried to couple mechanisms to address market failures with efforts to enhance transparency, because it is so crucial to understanding what's happening and where the market failure is. You know, it's hard for us to identify exactly what the sources of that failure are if we don't know what's happening with the cost of care, and we don't know how various providers, for example, compare to one another in that regard. And obviously it's hard. It's hard because different providers see different mixes of patients and they have different reasons to have the cost structures they do. So the goal is not necessarily to try and compare apples to apples all the time, but to do the best you can to identify what's happening will help move the ball forward in terms of being able to advance meaningful changes that will address some of these market challenges and market failures we're seeing, not just in California, but elsewhere.
So you mentioned some of the efforts of other states. So let me just stay with you for a minute, because we heard during this process from the chair, Dr. Stuart Altman of the Massachusetts Health Policy Commission, which was established in 2012, right after you were working with Governor Romney. So it may post-date you a little bit. But given your familiarity with Massachusetts and California, how might you compare the states in terms of the impact that setting cost targets might have and monitoring performance against them? Because that's what they did. Do you think, so I take it you think it'll be similarly effective in California, but might it be a little different?
Yeah, I mean, it's certainly going to be different because the nature, I mean, obviously California is much bigger and has a much more diverse population than Massachusetts does. Although that having been said, there are a number of similarities if you look at the makeup of the healthcare marketplace and certainly the marketplace around providers. Massachusetts is dominated by a couple of very, very high quality academic health centers, and then a number of other healthcare providers that are largely fairly balkanized and have the ability to drive pricing in much the same way we see in California. We have some very top end academic medical centers up and down the state, from Davis to San Francisco to LA. Down into Orange County and San Diego. We also have a lot of consolidation in our provider communities, particularly in the northern part of the state, in the Bay Area. Southern California is a little better, but it's not great still. And so some of the factors that we're seeing in California are relatively similar to the factors at play in a place like Massachusetts. And in Massachusetts, there has been an effort in the wake of the healthcare reform law passed in the mid 2000s under the leadership of Governor Romney and the Democratic state legislature there in Massachusetts. There has been an effort to try and continue to implement the law in as positive of a way as possible. And one of the innovations that they came up with, actually that postdated the initial passage of the law, was the creation of this healthcare cost commission. And other states have tried to use similar examples. Maryland, for example, has a slightly different variation on a theme, but the idea is to create a statewide global cost target in Maryland. Massachusetts has the notion that they are going to examine each of the components of spending and figure out how to keep costs under control. But the idea is simply that if you are able to set a target and work against it, that's much better than kind of just flailing around and doing what you're doing. At least you can have a sense of how these different components are comparing to one another, what's contributing to the cost growth, and you can begin to address some of the underlying issues. Look, I think consolidation in healthcare is a big challenge. And unless we get serious about addressing the challenge of consolidation, that's both vertical consolidation, where you see, different entities coming together. In some cases, it does provide better quality care. In other cases, it's anti-competitive. And then you have traditional horizontal consolidation, which is, creates competitive concerns for a number of different reasons. Unless you can start addressing some of that consolidation in the healthcare marketplace, you're not going to get to a better cost structure. And that's something that Massachusetts and Maryland, for example, have taken very seriously. And I think in California, we need to begin to take a hard look at what we can do to move the ball forward on those dimensions as well.
Mm-hmm. So Laurel, and by the way, we heard also from Robert Murray, who was the former executive director of the Maryland Commission that you mentioned. And so this group took a look at several other states and coming together around this. But Laurel, I want to give you a quick chance to jump in here on the data issue, because Bill started with the need for data to provide transparency. And you just heard Lani mention it, and that's certainly what Massachusetts did when they initiated their health policy commission. At the same time, they created a statewide database to interact with it and give them a basis for the work they did. So why is data such a big deal? Any further comments you'd like to add?
Yeah, I think having the data is really foundational to this proposal, and there is a separate process already underway in the state to create a healthcare payments database, which is overdue in this state. But I think the idea behind this commission or office would really take that data and build upon it by providing the transparency not only to consumers but also to purchasers who even purchasers have limited information about what they're buying and what the prices are, and how providers compare in terms of prices. And also in terms of setting the cost target and tracking provider and health plan performance on that cost target is really making use of the data. Data is necessary but not sufficient for controlling costs.
Mm-hmm. Well, I want to put up just one more bit of data just for a quick commentary, because I want to make sure we save some time to get to audience questions that have come in. But if we could put up the last slide that we had, that we are using with the permission of Christopher Whaley at the RAND Corporation, who used it at that Assembly Health Informational hearing last week. This shows 31% higher inpatient hospital costs in Northern California than Southern California. 23% higher overall hospital costs, and 43% higher premiums for insurance obtained under the ACA. And the bottom two bars show that it's not explained by average income or home value. So Bill Kramer, you want to take a quick shot at what's going on here? Because this is not exclusively, but primarily a Northern California audience. So just thought they would be interested in knowing this data.
What's going on here is market failure, or more accurately, the result of a lack of healthy competition in Northern California among hospitals, health systems, and physician groups. And just to reiterate, this is not driven by the different costs of running a hospital in Northern California versus Southern California. It's driven by higher prices in Northern California, higher prices for the same services, and by the way, for the same quality outcomes. RAND has done some outstanding work across the country looking at state and local markets. Their analyses show that the prices charged to those with commercial coverage vary tremendously. And it depends on the local market dynamics. Lani referred to the issue of consolidation in the healthcare industry. That is a big factor in many markets around the country. Boston is a good example of that. And Northern California is a good example of that. And sadly, some of those big health systems have used contracting practices to further strengthen their market power and raise prices. So we need to address this problem of consolidation, certainly make sure that any anti-competitive contracting practices are not allowed. We want healthy competition. We believe market forces should work. Government needs to set the rules for how that competition should work to make sure that those that are delivering the best value to consumers, to patients, at the best quality, to lowest price, are the ones that are going to succeed in the marketplace. If we can restore that kind of healthy competition in Northern California, I think we'll see value to patients, consumers, small and large employers across that region of the state. And hopefully we can maintain the relatively healthy competition that currently exists in Southern California and head off any drift toward further consolidation there as well.
And this office could help with that.
Exactly, because it'll be tracking what's going on. That's a key part of it. So we don't have to do a special study every couple of years. So we'll be able to track it much closer to real time. And then it'll be connected to setting the targets, providing the kind of technical assistance, and with consequences for those health systems, hospitals, clinician groups that are not achieving those cost targets.
Thank you. So some of the questions that we've been getting in ahead of today and today, one of them I can kind of summarize in. So we released this report in March. The pandemic hit. Anybody, I'll throw this out to any of you, is it still relevant? Any of you want to look in their crystal ball? And no one saw this coming, so we won't hold you to it. But what do you think might happen with the proposals that at least Assemblymember Wood is going to reintroduce?
Let me take a crack at that. I mean, COVID doesn't change the underlying dynamic and the underlying problem we have around the cost structure of healthcare in the state. It doesn't change. In fact, if anything, it exacerbates the consolidation issues that Bill's talked about. One of the challenges we've seen amongst providers across our state, healthcare providers across our state, is they're having difficulty, particularly smaller independent practice groups are having a difficult time staying afloat because of the fact that their volumes have plummeted because of COVID. Now, some of that's coming back. We're starting to see recovery in the healthcare sector, and that's a good thing. But make no mistake, it's going to make consolidation worse, not better. So the fact that we've had COVID and the related challenges tells us that we've got a lot of work to do. And if anything, that work has gotten harder, not easier, over these last several months.
Right. So another question that sort of combines things. So single payer, there was a lot of talk, particularly in this state, about single payer, particularly a couple of years ago. We had people in our room who were on, we lost Lani. Hopefully it wasn't a single payer thing. we had people in our room who were on both sides of the single payer debate. But yet they came together around this one. So why do you think, not even just on that issue, but why do you think that opposing stakeholders are typically opposing came together around this proposal?
I think this idea was supported by people in both camps, people who support single payer and people who don't, because it's relevant in both situations. We've already talked about why this proposal would be valuable in the context of our current system, but I think it would also be valuable in the context of a completely overhauled California healthcare system where everyone is in the same statewide program, and we've eliminated the distinctions between job-based coverage, Medicare, Medi-Cal, et cetera. In that situation, we'd have to find some way to raise new revenues to replace the money that employers and workers are currently spending on job-based coverage. And most likely that would be through new or increased taxes of some sort. And policymakers and voters would want to be assured that those tax rates aren't going to be increasing year after year as if healthcare costs continue to grow more than the rest of the economy grows. And in 2017, Governor Shumlin of Vermont, who oversaw their state's process to try to move towards state single payer, which didn't ultimately pan out, but they went pretty far down along that path. He said that this was a really important aspect of getting to single payers. You have to get cost control under control so that people can feel assured that the tax rate isn't going to grow and grow each year.
Mm-hmm. Others? Either Bill or Lani want to jump in on this one? Why were opponents and supporters of single payer able to come together on this?
Well, very briefly, this is a big topic, but very briefly, it's very hard to do single payer at the state level because of Medicare, because of self-insured, large self-insured employers that are exempt from state regulation under ERISA. And then, of course, the issue of cost containment, while at the same time you're trying to provide coverage to everyone. So I think the group decided, like, whether one agreed with the long-term goals of single payer or the ways to get to, the best ways to get to universal coverage and cost containment, there's stuff that needs to be dealt with right now around costs, and there's steps that can be taken right now. It doesn't mean we're on the road or not on the road to single payer, but whatever solution we have to making sure people have coverage in California and across the country, we need to do something about costs. There's enormous waste in the healthcare system. We can provide as good or better quality care at lower costs, whether it's funded completely by taxpayers, funded through the employer-based system. We need to get those costs under control. There are steps that can and need to be taken now, and those are that's the topic. Those are the issues we converged upon.
Fabulous, fabulous. So we're getting toward the end of our time, but just quickly, we had a question. Oh, there's the assembly member. Maybe you can just do a super quick answer to this one. One of you, we didn't mention pharma costs in our report, and we didn't have a pharma rep at our table. Can somebody give me a fast answer as to how that works out and why?
Let's see who's pressing the unmute button first. But I'll take a shot at it, but Laurel and Lani might have a comment too. Reality is that most of the regulations, the laws and regulations around drugs, about how they're approved, and what the patent law is, and how costs are managed, is done at the federal level. So there are actually not a whole lot of levers that the state can use to contain drug costs. There are some good initiatives underway, but ultimately, to get control over drug costs, we need to do something about how drugs are approved, how the research for drugs is financed, how patent law works for both traditional drugs as well as biologics and biosimilars. Those are enormous questions for the nation to grapple with, and the way that our laws currently work, most of the regulation of drugs is done at the federal level rather than the state level. So we decided, while drug costs are a serious problem, it's not something that we could take on and fix easily at the state level. We decided to focus on what we could get done around hospital physician costs.
Thank you, Bill. It's unfair to ask you to put that in such a short answer, but I'm delighted the assembly member has rejoined us. So Mark, any other questions from you?
Yeah, thank you so much, Vicki. And have a quick question for you, actually, and if anybody else wants to jump in. But now that you've seen the convergence process play out, and I think really so successfully, do you think it's applicable to other intractable issues in the state? What's the secret sauce, and how can we scale this to other really important issues?
Well, yes, definitely. It's transferable to other issues. That said, this isn't the right process in every context for every issue. Sometimes if there's serious differences of opinion, or sometimes maybe even a stakeholder's being disingenuous, you just have to garner the votes and move forward. But much more often than not, you don't have to. And the problem with doing it the first way is that legislation under those circumstances doesn't always have a lot of durability or staying power. And when the votes shift, the laws sometimes get undone. So history shows us that transpartisan legislation has more staying power. But we've all seen it's hard to do. You've been amongst it, but primarily for two reasons I think that are challenging. One, we humans are bad at communicating, and we're even worse at it when in a charged environment, such as around hotly contested issues. And two, it can be hard to start a conversation or continue a conversation if you believe it makes you look weak or lack of resolve, right? And so convergence helps with both of those problems. We bring in a skilled facilitator to help with communications. And in this case, I benefited from both my mediation background and having Mark Zitter and Daniel Bowling, who are also skilled at this, to come in and help facilitate the conversation. In addition, convergence is the one that invites the people to the table, and convergence is the one that keeps scheduling it and keeps the conversation going. So no one has to, be the one who reaches out first. So we create a place and a space for those who want to do what President-elect Biden urged, to choose to cooperate. So our secret sauce is really giving parties a chance to be creative, try things out off the record where they can be more candid and curious, and seek reaction to those ideas, and recognize, hear and see each other, and all these things that these panelists did and have talked about. And I think it could translate to a lot of different circumstances, whether it's housing, education. There's quite a few. So the economic and regional divides, digital divides, all of that. So yes.
Really appreciate that. And I mean, as we saw with the election, sometimes the legislature passes bills and then the public voters, choose decide that wasn't a good idea. And that doesn't happen when we have broad consensus on issues. So I think that's a really good point you made and really appreciate that.
Mm-hmm. So I think we're out of Q&A time. So I want to thank our panelists, Bill, Laurel, Lani, for joining us today, and again for joining us on this long journey. And we'll see what happens, and we may, we hope to support and get your word out as you go forward and do what you do in Sacramento to try to see this thing through. But thank you so much for joining us today. And just
and
for
thank
me,
you. I want to thank you.
Well, I was just going to say,
Sorry.
and Assemblymember, your team working with you has been fabulous, and I want to thank Zach and Isabel and Ellen, and on my team I want to thank Doozy and Don and Jen and just the folks who've made this happen. I mean, healthcare affects every one of us directly, and a lot of issues affect us indirectly. This one affects us directly. And so, getting this work done, getting this word out, you allowing us to have this forum today is something for which we're really grateful. And I thank you very much.
It's my pleasure. And I want to thank you, Vicki, and our three incredibly esteemed panelists, Bill, Lani, and Laurel, for all of your great work and for putting together this informative and timely event and, really important and I hope successful proposal, because healthcare costs are something that have been going out of control for too long, as we all know, as some of those slides pointed to, and is such an important issue that, like you said, impacts everybody. So I also want to thank the whole Convergence team for your work behind the scenes to make this possible. It was a pleasure working with all of you. And finally, thank you to all of our attendees for joining us today, for being interested in this issue. I encourage everybody to go read the report. And just really hope you all have a great week. So thank you all so much.
Thank you.